Hello and welcome to February's continuing education. We're going to be talking about STEMIs and 12 leads. This is a really important lecture to understand because it's something that we do all the time with our patients, especially with patients that are having issues with chest pain or abdominal discomfort, or even people that we didn't think that would be having acute coronary syndrome can definitely present with signs and symptoms that are a little bit less apparent as someone gripping their chest. So the purpose of today is to review the 12 lead, make sure that we understand what the different types of STEMIs are, and we'll go through some scenarios like we normally do. So first of all, we need to understand 12 lead placement. It's very important that you are able to do 12 lead placement appropriately, and if you're not the one going to be performing the 12 lead, essentially putting the pads on, that you know how to explain it verbally. This is something that our EMTs are very capable of doing, and it's not something that if you have an EMT that you should be doing for them. This is a part of their repertoire. So one of the things that we need to understand is there's two different types of 12 leads, and even some would argue a third. And there's the left side, the right side, and then there's the posterior. So the left side is traditionally what we were going to be doing, and you'll see on the graph, or excuse me, on the chart picture here, that we have V1 on the 4th or 5th intercostal space on the right parasternal, and then V2. And usually what we do is we take a gap and we go directly inframammillary and probably about the 5th or 6th intercostal space, and that's where we put V4. You're going to trace a diagonal line up from V4 to V2, and you're going to place V3 there. Then the next one, you skip another one and you go to V6, and you go to the mid-axillary line along that same intercostal margin and you place V6, and then directly between you put V5. Now I know that sounds surreptitious. If you learned it another way, that's more than appropriate as long as we get the correct positioning. We don't want to be putting the precordial leads up on the shoulders or higher than the 3rd intercostal space. You want it to be at the level or just underneath the nipple line. That can be somewhat difficult, especially with people with gynecomastia or large breasts. You won't be able to clearly see where the nipple line is, but what we can do is we can identify where that 4th intercostal space is, and if you need to walk down the rib margins, then do so. A good 12 lead is very important, especially if it's going to determine if you're calling a STEMI or not. You should always check the lead placement whenever you get something, especially if the 12 lead looks off. The other side is the right-sided chest lead placement, and you can see here it's essentially the same format except it's on the other side. You would be doing these for concerns if you are having an inferior wall MI or even a posterior wall MI. Now the third one I mentioned before that's not listed is where you take the leads and you put them on the back of the patient along the scapular margin in the same general vicinity of where you would be doing the left-sided. And for this you might have to eyeball it a little bit, which makes it a little bit more challenging, but very effective whenever you have a posterior wall MI that you can see in the precordial leads that is just signified as a elevation only in V1 or V2. And finally, on the right here, we see where we place our limb leads. This is one presentation. You can put it at the chest wall as well as the bilateral lower quadrants of the abdomen. And you can also put it on the distal extremities. Some argue that putting them on the distal extremities, both in the radial area of bilateral arms and the medial malleolar area of bilateral legs, is going to get you a better result. That's neither here nor there. They're non-inferior to one another. But what I will suggest is that you always make sure that you do not put the lead on a bone. It always needs to be on the muscle. So let's talk about patient number 1, John Doe. It's a 54-year-old male that has shortness of breath, chest pain with near syncope for 2 hours, doesn't have any medical history, he's holding his chest. Alright, so let's talk about what we need to do for our primary survey. This is very important. This shouldn't take you more than 45 seconds to a minute. It's to identify life threats. You need to ask the patient their name, listen to breath sounds, watch the rise and fall of the chest, feel for any type of palpable pulses on the radial side, especially if you're concerned for a cardiac issue. Just looking at them or depending on the monitor isn't enough. You need to feel for the pulse. Looking to see if they have any type of weakness, altered mental status, or anything that would indicate that they have poor inner cerebral pressure, and then exposure if they have any rashes or anything if you're concerned for sepsis and whatnot. So going in here, we see that the patient is able to state their name, they have clear bilateral breath sounds, they have a 1+ regular pulse that is irregularly irregular. If you see that on a test, it's AFib or aflutter into improvement otherwise, and if you feel it, it could be PVCs, PACs, or AFib, aflutter. Don't just jump to the conclusion that because I feel irregularity that it's AFib or aflutter. PVCs can be very misleading when it comes to that. So the patient reports weakness and lightheadedness with standing. That indicates that we might have an unstable patient. We need to get our secondary survey with our vital signs. In addition to that, we don't need to expose the patient because it looks and appears like it's going to be cardiac in nature. So this right here is our 12 lead. And whenever you have a 12 lead, we all have our ways of interpreting. One of the things that you need to do is create a way that is uniform and standard, and you do it every single time. You can't just eyeball the 12 lead and say, well, this is what I think it is. You need to be able to interpret the 12 lead, because that's why we went to classes and have this task. And so the first thing is that you need to identify rate, second, rhythm, third, P-wave morphology, fourth is QRS morphology, and then you're going to identify the T waves, the ST segments, and then your axis. So we're going to talk about that, and then we'll briefly go over them in the additional 12 leads that we're going to go over. So as you can see right here, you have the limb lead that's giving you lead 2 that's traditionally referred to as the rhythm strip. But I'll challenge you. The rhythm strip in lead 2 does not always give you the best picture of the P-wave morphology. Instead, V1 will give you the best. And as we see up here, you see that there may be a P wave, there looks like a P wave, there's no P wave, and then you see multiple P waves. So you have some, none, and multiple of different shapes and sizes. And so therefore, this would most likely indicate that you have a supraventricular problem, meaning above the AV node. And if you go down to lead 2, you can see that you have beats that are irregular, and then the next step is you need to decide the rate. And so we have rhythm and rate. Is it fast or slow? Some resources will say 140, some resources say 150 to determination of AFib RVR. But in order to count the rate, you have two options. One, you can look at the monitor, which isn't always right. Sometimes the monitor can tell you that a patient in normal sinus can be in supraventricular tachycardia because the equipment and the software are overcounting. So instead, you need to count by yourself. If it looks fast, it is fast. That's a good way of determining. And if you're on the borderline of determining, is it fast enough for me to treat? Is the patient symptomatic? This patient is altered. They have weakness. They don't feel well. That sounds pretty unstable to me. The second another thing that you would need to look at, and I say unstable when I mean for ACLS protocol, but ACLS is different than real world, as we know. You're not going to automatically go and synchronize cardio over somebody. You're going to try medical management first. So for this patient in AFib RVR, we need to determine, do they have another thing going on? Do they have a STEMI? And so like we mentioned before, your QRSs are tight, less than 120 milliseconds. And then you go into your T wave. Are they upright or inverted? Well, some are inverted, as we can see over in AVL, and that may just be a PVC right there, but most likely it's an inversion there. That's an abnormality, but it's not sustained. So T wave morphology in this 12 lead looks generally uncompromised. And then you look at the ST segments. ST segments always want to make sure that you find the isoelectric line, which is the line in which you have your P wave, and then you have where you're going back up to your T wave, and they meet in that middle. And so if you have any type of deviation from that, that's a depression or an elevation. And we see here that you have depressions in V2, V3, V5, V4, and V6. You don't see any really in the 1, 2, 3, 4, or excuse me, 1, 2, 3 AVF or AVL. But it is not unusual for a patient in AFib RVR to have ST changes. It doesn't necessarily mean that they're having a heart attack, but what it does mean is that the heart is working at a rate that it is not accustomed to and it does not like. And so we need to get this patient back into a rhythm that's appropriate. So we have identified everything up until the axis. The axis is really kind of just a cherry on the top. It's meant to be an additional qualifier to help you determine whether or not patients are going through heart changes. Do they have abnormalities on their 12 lead that would push you into a treatment area more than the other? And for the pre-hospital setting, just for the purpose of this 12 lead, we're just going to go over a simple method to be able to identify and check the axis. Will it change your methodology? Most likely not. But for those of you who are interested in what that means and how to check it out, here's how you do it. There's multiple ways. Personally, the one I use is the thumbs up method. If you take your left thumb and you make it the direction of the QRS complex in lead 1, and then you take your right thumb and you apply it to the direction of AVF. So in this case, 1 is up, AVF is down, and so you're going to be going to a left axis deviation. If on the other hand, 1 was down and AVF was up, you're going to be going to the right axis deviation. If they're both up, that's normal. If they're both down, that means an extreme axis deviation. These things are really important for our congestive heart failure patients, our patients with pulmonary edema, pulmonary hypertension, things like that. It's not really of great utility for you in the hospital, the pre-hospital setting, but it does assist us in management in the hospital setting. All right, so what is the disposition of this patient? What's our preliminary field diagnosis? We've talked about it multiple times. It's atrial fibrillation with RVR. How do you treat this? What do you need to do? What are the critical tests and procedures that we need to? If it's too fast to see, meaning that it's a greater rate than 200 and it looks like it's just blended, it can be confused with a supraventricular tachycardia. In the previous 12 lead we just reviewed, it is unnecessary to give adenosine to this patient because we can clearly identify that it's atrial fibrillation. On the other hand, once you do identify it, cardizem for control or metoprolol for rate control. If they're unstable, meaning that they have hypotension, they're having just chest discomfort with hypotension, you have a mixture of objective and subjective signs that the patient is not doing well, then you can synchronize cardiovert, and you want to consider sedation with that. What's the determination of disposition? Well, you need to go to the closest emergency department. You know, if this patient's unstable, absolutely. If the patient's stable and you're not either AFib chronically, then this patient can go to a patient choice or one that's open. So here we have our interpretation of the rhythms. AFib, you can see that if we walk it out, we have 1, 2, 3, 4 boxes, and then we walk it out again and it's less, then we walk it again, it's less, we walk it out, it's less. And so therefore we have these instances in which the fibrillatory waves, which you can very carefully see in this 12 or this rhythm strip, that you were not able to appreciate the P waves. It is irregular. It has no cadence to it. And so if you see this, it's AFib. A flutter, on the other hand, is what we would traditionally refer to as the sawtooth waves. And they can come in 2 to 1, 3 to 1, 4 to 1 distribution and conduction. And so these patients can also have the same manifestation of instability that you would definitely see with AFib with RVR. Speaking of PVCs and PACs, I loped this in here because when you're feeling for a pulse, you can say, oh man, it's fast and they're in AFib RVR, but it may be a PVC, and that's why you need to have a 12 lead, you need to have a rhythm strip whenever you identify these things. And so some of the causes with PVCs and PACs are hypoxia, MI, electrolyte imbalances, specifically potassium, digitalis toxicity where they use digoxin for congestive heart failure, or congestive heart failure in and of itself, or idiopathic. In addition, PACs can be COPD in nature, and so we commonly see these with multifocal atrial tachycardia, or MAT for short, and you see this type of an instance when you have someone who's chronically hypoxic, like with our COPD patients. So let's go into patient 2, Jane Doe. She's 63. She's having shortness of breath and chest pain with fatigue for several days. Sounds like a general patient. Again, gearing up to what we need to do, your primary survey less than 45 seconds to a minute. What do you need to do for your airway? Ask their name, look at their breathing, listen to their lung sounds, feel for their pulse, and evaluate if they're having any type of changes in their disability or their neurological status. So here we see that she's able to state her name. She has clear bilateral breath sounds. She has 1+ radial pulse with weak and thready but regular. All right, so now we have a different rhythm. The patient reports that she's weak and has fatigue, and the exposure is non-contributory. We're not concerned about rashes or anything like that, although we will talk about rash in just a minute with this type of a case. Here we have the 12 lead, and like we talked about, we have to rhythmically go through this in a universal method that you can reproduce every time. Rate, rhythm, P, QRS, ST, T, and our axis. Again, axis is the conditional one, but here we can see our rate is slow, much slower than the one before, and our rhythm strip on lead 2 down here, if we walk this out, this is much less than 70, and so therefore this patient is bradycardic. But what is different about this? And this is a repeat of ACLS. We look at our P waves, the very next one, we have upright P waves, but then we have missed QRS complexes. And we have to determine, do we have elongation? Do we have just a random beat drop? Do we have discontinuity between the QRS and the P waves? And that's what it looks like. It looks like a 3rd degree heart block. 3rd degree heart blocks are serious. They can kill patients. And so we have to continue. The QRS is tight. The T waves are present. The ST segments are universally isoelectric, and our axis, well, it looks a little left-sided, but that's beside the point. So we need to think about, what do we need to do? So again, we need to think about what is our preliminary field diagnosis. Here, in this instance, we have a discontiguous P and QRS complex, but we have stability and it walks out. That means it's third-degree heart block. In addition, what critical test procedures do we need to do? Well, if they are symptomatic, you can consider atropine, but I put this in here to have a discussion. Third-degree heart block, atropine won't really work for you. The only thing that does work is pacing. And so therefore, the patient, if they are unstable, which most of the time they are, you're going to have to do transcutaneous pacing with them. And so you need to know how to make the monitor go into the pacing regimen. You need to be able to document that you've done the pacing. And again, you need to consider pre-procedural sedation with Versed or anxiolysis, as we like to call it. And so you can use fentanyl or you can use Versed for that, which would assist you in allowing the patient to let you do the pacing while they're still awake. What's the determination of disposition? Well, if they're unstable, you need to go to the closest facility, and if they are okay, then it can be patient preference or whomever's open. So let's just quickly go over the interpretation of our different types of heart blocks. First degree, you can see that the PR interval is greater than 220. Some cardiologists will say 200 milliseconds. That's okay. It's prolonged. It's greater than 200. And the second degree type 1, as you can see, we progressively get longer and longer until we have a drop beat. And then type 2 is we have this drop beat and then QRS, QRS, drop beat, QRS, QRS. And then with our third degree, you have our P wave, QRS, P wave, QRS, P waves in there, and then we continually have going through it. So with that, second degree type 2 and third degree can be a little challenging to differentiate, but it's that fine line between where we are at in terms of the degree of the heart block. Now you'll notice here that unstable is pacing and atropine, and then unstable is pacing and stable is pacing. So we need to make sure that we are adequately prepared to perform this sometimes life-saving intervention. And I know it can be scary, but at the same time, this is a very dangerous rhythm because the heart's really not moving, and you're either going to throw a clot, you're going to have a stroke, or you may have a heart attack. So this can be very difficult, and the ultimate destination for this patient is into cardiology for intervention with a pacemaker. So patient 3, Joe Doe, 42-year-old male with complaints of chest pain for 2 hours after inhaling cocaine. So we need to make sure that we are aware. Oh, I forgot to say, on the previous slide, which I can't go back because I'm recording, but there is one instance in which we need to be aware of a rash causing this, and that's tick-borne diseases, specifically Lyme disease. Lyme disease is notorious for causing third-degree heart block if the tick is engorged and left on, and also it can cause paralysis for no reason. And so if you're concerned that you're going to a patient that's been hunting and now they're having this like shortness of breath and they have this rash and looks like a target on their body, look for a tick. That's a good way of determining it. I know that's a little extra, but that's why the exposure is important with that kind of a patient. But back to Joe Doe doing cocaine. Again, our primary survey, are they talking? Do we have clear bilateral breath sounds? What's our circulation? They are talking. He has clear bilateral breath sounds. He's got 1+ radial pulse, weak and thready, but it's regular, and he reports weakness and fatigue, so you have a potential for instability. Going into our 12 lead, this is what we see. By looking at this rhythm, it is a QRS that's wide and regular, and it's tachycardic. So that most likely means that we are in VTach. All right, so let's go through our primary survey with this patient. What do we think is going on? VTach. And what tests do we do? Well, we've already done the 12 lead, get our IV, prepare for the worst, prepare for this patient to go into arrest. But what do we need to do medically? Well, amiodarone is an excellent drug for this. 150 milligrams IV push over 10 minutes. You can put it in a bag and let it drip in. And then if it doesn't work, you can do another one. If the patient's unstable, then we need to do a synchronized cardiovert. Again, preparing for the worst. What is the determination for disposition? This patient needs to go to the closest facility to be able to assist them through their crisis. So our other different types of rhythms are SVT, AFib RVR, which we've already talked about, and WPW. So we see right here our unstable is cardioversion and cardizem, like we talked about before, or metoprolol if you have it. Cardizem is our stable go-to, it is usually 0.125 to 0.25 mg per kg with a max total dose of 25 milligrams. IV push, okay. I would just be hesitant about giving that full dose. There has been evidence, both anecdotal, myself, as well as research that has shown that if you give this faster than 2 minutes, or if you give a large dose, it could cause the patient to have a sinus pause, arrest, become hypotensive, become symptomatic. So you just want to remember that if you give it, you can't take it back. So be careful what you give. Now, SVT, on the other hand, is a fast rhythm. Its QRS can be wide or narrow. Most likely it's narrow because it's supraventricular. And so most of the time it's going to be narrow. If it's wide, it's VTAC. But when you have SVT, you need to make sure that it's not AFib. That's just masking. So you would try vagal maneuvers if they're stable, giving adenosine. Some say 6-12-12. Other services just went directly to 12-12. And you can even try cardizem or amiodarone as a third and fourth line drug. So unstable, on the other hand, you're going to cardiovert with the addition of possibility of adenosine or cardizem. But if they're unstable, you go directly to that. Now, I put in those other options in there just because of the fact that sometimes you'll do medical management first and try your hardest to avoid electrical cardioversion. But a lot of data that has come out has actually shown that it is better if the patient is unstable and you cardiovert them and don't try medical management first. Now, unstable, on the other hand, is WPW. WPW, you'll see right here, is that common delta wave. I'll highlight it right here. This upslope rapidly up here, and Wolff-Parkinson-White is due to an alternative pathway through the AV node, and so thereby it causes that rapid upslope. And behind this picture, you can see that it can even cause something that looks like VTAC. So the treatment for this is not amiodarone, it is not adenosine, it is not cardizem, it is not metoprolol, it is procainamide. And we used to carry procainamide a lot, and we don't carry it as much because it's not as recurrent. If they're unstable, you're going to cardiovert them anyway, and it can put them back into a hemodynamic rhythm. And so thereby, if you see this and they're fast and they're symptomatic, IV fluids, just try to manage it, and most of the time you're going to let the emergency department handle this part. So here we see the different levels of rhythms, and the reason why I pull all these rhythms in this order is because I want you to understand that from the top, you can probably get them back. Now at the bottom, the chance of return of spontaneous circulation is greatly decreased. And the reason for that is because of the theory that is revolving around ATP, or adenosine triphosphate, which is, we can pull back to the academy days, that is the currency of the cell, or the energy of what our cells use. The heart and the brain are the most glucose greedy. Glucose is broken down into ATP. And this isn't a biology lesson, but what I want you to understand is that under normal circumstances, the ATP, or currency, we're going to use a bank model, that the cell inside and all the machination and everything like that that's going on inside is constantly depositing and withdrawing ATP to a net negative for the most part. And it's going to take more and then try to reproduce, and that's why we have to eat. On the other hand, whenever you have an acute event like a stroke, sepsis, STEMIs, now you're in even greater net negative and you can't keep up. And so what happens is that the heart, because it is so greedy, it has a very limited reserve in the bank. And so when it runs out, that's when you start to degrade down into different levels of these lethal rhythms. So it doesn't always happen that I have low ATP, so I must be asystole. No. But what I am trying to do is a general concept to understanding why we defibrillate. And so in VTAC and VFib, you can see that they kind of resemble a rhythm. VTAC more than VFib, obviously. And that's because they still have enough energy to kind of keep the machination going as best they can. Now, when you go down into torsades, it's kind of a special rhythm. It kind of looks like both. We treat it a little differently. But in asystole, on the other hand, there's nothing. I mean, it doesn't look like anything. And so therefore, you have this rhythm that has no currency whatsoever. So if you defibrillate it, you're not going to get anything. If you pace it, you're not going to get anything. You're literally just going to cause an electrical signal to go through the heart, and it's not going to regain that mechanical capture, which is so important and which is necessary in order to get return of spontaneous circulation. So With our VTAC and VFib, you see here unstable, you're going to defibrillate. If they are awake and they have VTAC, you can cardiovert them or synchronize cardiovert. If they're not awake, they are defibrillated. Amiodarone for our VTAC VFib, if they're awake, at 150 milligrams IV push over 10 minutes. And then you can repeat that. If they are not awake, then it's amiodarone ACLS. Now, if they are getting CPR, remember your epinephrine and your H's and T's. But if they're stable, amiodarone's your go-to. Now, on the other hand, torsades, if they're awake, you're going to use magnesium sulfate. Then, if that doesn't work, you can try amiodarone. Remember, there's only a limited amount of time until this patient's going to go unstable, and so you're going to ultimately revert back to defibrillation. You're not going to cardiovert this. I put this in here to talk about it. There's nothing to synchronize to this, so you're going to defibrillate. And then amiodarone, CPR, epi, and your H's and T's if you're undergoing that route. Asystole, they're unstable. There's no one can be alive with asystole, and so you're going to do CPR and epinephrine and your H's and T's. So let's revisit the 12 lead a little bit and look at the specific areas. This is very high yield, and you need to understand what you're looking at when you look at the 12 lead. And so your 2-3 AVF is your inferior wall. There's a picture on this next slide that we'll show where these look at. But the inferior wall is looking at the inferior part of the heart, specifically the right atrium and the right ventricle. Now, on the other hand, your lateral, or 1, AVL, V5, and V6, is looking at your lateral wall. And you can see the circumflex branch is right over here. And so you're looking at this part of the heart. Now, the septum anterior is your V1 and V2 specifically, and it's looking at the area between your right and left ventricle. Whereas your anterior septal, or V1 through V4, is taking into consideration the septum as well as predominantly the left ventricle. This is going to look at your left anterior descending, and in your inferior wall, like we mentioned before, this is your right coronary artery. Now, there's a lot of things that with the right coronary artery that's very important. Your right coronary artery provides blood to the pacemaker of the cell, and so that's your SA node and your AV node. And so although there is some blood flow over from the LAD, if you blow out your RCA, these patients are most likely going to be bradycardic. And so there's a lot of special nuances when it comes to the inferior wall MI that you need to be aware of, like fluids before nitroglycerin, getting your IV before nitroglycerin, being very careful with nitroglycerin. And so there's hint, hint, hint. So make sure that we are identifying each of the different types of STEMIs, and we'll go over that in the proceedings or the next slides. Here's that next picture that I was showing you about, and we look over here. This green area is involved in the inferior and right ventricular infarcts, and then your yellow area is the septal infarct, because this is where the septum is. The left ventricle is much bigger than the right ventricle, but look how much is affected from this inferior wall MI, from the inferior corner, or the right coronary artery, excuse me, and its branches. Now, the left anterior descending, as well as your left circumflex branch, you'll see over here the purple is involved in the lateral infarcts, and this is going to be supplied by this left circumflex, excuse me. But in your anterior septal, you'll see here your LAD is coming down in your marginal branch. So it's very important to understand not only what you're looking at, but understanding where you're having the problem at. So Janice Doe, 56-year-old female with complaints of epigastric pain and mild nausea for 3 hours. It can be abdominal pain. It can be cholecystitis. It can be epigastric problems. It can be, gastroparesis. It can be a small bowel obstruction. It can be a large bowel obstruction. It can be GERD. It can be bad food. Who knows? But what we cannot do is we cannot discount a advanced age female that is now complaining of these subtle signs that has been historically and research-based methods shown that these patients could be suffering from myocardial infarction. So looking at our primary survey, she does state her name. She has clear bilateral breath sounds. She has a weak and thready regular pulse, all right? And the patient reports that she's weak and fatigued. Okay, maybe she hasn't been eating. Maybe she's got nausea and diarrhea. We still don't know. But what we do need to do is we got to get that 12 lead. And here we see the 12 lead. Man, we look at our 12 lead again. we're looking at, we don't really have a rhythm strip over here, but for the general purposes, it looks normal sinus, maybe a little bradycardic. But now we go to our ST elevations, 2, 3, AVF, 1, AVL, V5 and V6, and V1 through V4. And this is a V4R, it indicates right there. You'll see right here, we have the isoelectric line, but nothing but man. ST elevation in lead 3, and then we have ST depression in lead 1. And then we look at over here, our lateral lead's a little ST depression, and you can't see behind my big head, but we don't see anything, but we do see some there. So this is a STEMI. You have ST elevation in lead 3, and you have it in a contiguous lead with, or excuse me, a contiguous lead with reciprocation. And that's 12 lead, that's STEMI. So this lady is having a inferior wall MI. What do we need to do with this? Well, we have to give them IV fluids. In certain systems, there's no nitroglycerin. This is service specific, but we want to be very, very, very careful that you provide them fluids, because like we mentioned before, that right coronary artery that's coming on the right side of the heart, on the right ventricle, right atrium, it's not only providing blood flow to the pacemaker of the cell, but it's also making the blood go to the part of the heart that sucks in the blood from the rest of the body, providing preload. And so you need to make very, very sure that if you're going to give nitroglycerin, which affects preload negatively and afterload negatively, that you're not going to cause a steal, which means that you're taking away the blood that's coming into the heart, and thereby there's no more blood left, thereby exacerbating the situation and making the situation worse. So aspirin, pain management as necessary. Morphine is not the primary go-to anymore. It's fentanyl if you're doing pain control, and making sure that you give them oxygen. You don't need to blow them away, but at the same time, in the pre-hospital setting, it's not unusual to have a non-rebreather mask on at 100, 15 liters per minute to give them oxygenation. That does change in the hospital, because it has been shown that there are some things that happen for long-term use of oxygenation like that. What's the determination of disposition? Well, if we said STEMI center, you are correct. And so let's go to the next scenario. Jelly Doe, 72-year-old male with complaints of left arm pain, jaw pain for 3 hours that's progressively worsening. I mean, that screams STEMI, unless they hurt their shoulder. So primary survey on this, he's got the ability to say his name, he's got clear vital breath sounds, he's still got a weak and thready pulse. He reports weakness and fatigue and rash, exposure, non-contributory. So the 12 lead, on the other hand, we look, rate, rhythm, PQRS, T, and ST. Man, first thing that blows my mind, 1, AVL, V5, V6, but man, look at this. We got V1 through V4. So we do have some reciprocal changes in our inferior lead. Again, this is a anterior lateral STEMI. How do we know it's anterior? Because it's 1 through 4. How do we know it's lateral? 1, AVL, V5, and V6. Anterior lateral. We need to make sure that we know, because that means that we got a big problem going along the entirety of the left ventricle, which is going to be our pressure out into the body. And if our ventricle is not working, we're not getting any blood to the heart, we're not getting any blood to the brain, and that's a problem. Going into the disposition, what's our preliminary field diagnosis? Anterior wall, anterior lateral wall MI, like we said. And then what critical tests do we need to do? IV fluid, nitroglycerin, aspirin, pain management. Make sure you keep their blood pressure greater than 100 systolic. Don't blow them out with the nitro and cause steal. And that's how you do that, even if it's not an inferior. If the blood pressure is too low to sustain and you make it go even lower, you're going to have a problem. So what is the determination? STEMI center. So patient 5, Jackie Doe, 58-year-old female with complaints of left arm pain, jaw pain for 3 hours. So this is somewhat of an unusual presentation. Women don't usually present with these classical signs of angina. And so our primary impression, what do we see? Everything else looks pretty normal. Got to get that 12 lead. We get the 12 lead, and now we see 1, AVL, V5, V6, V2, V3, V4. So again, what does this mean? Well, is this a lateral or anterolateral? Well, it looks like it's both. And we also have ST depressions as well. So it's not unusual to see the anterolateral coming, because as we remember from that blood flow, if it's proximal enough, meaning that it's coming directly from the feeder source from the heart into the heart's own vessels, it can include both. It just depends. Depends on where that clot is at. Depends on where that occlusion. So what is the preliminary field diagnosis? Is the lateral wall, anterior lateral? You're not wrong if you say either one. What critical procedures do we need to do? IV fluids, nitroglycerin, making sure you maintain that blood pressure greater than 100 systolic, aspirin, and pain management. Again, morphine isn't first. It's going to be fentanyl. And then what's your determination for disposition? STEMI center. So that concludes this month's CE. Please fill out the questions on the attached Google or the form that we have for our questions so we can get you credit. If you have any questions, please reach out. Remember, STEMIs and 12 leads are very important. If you think that it needs to have a 12 lead, it probably does. We miss STEMIs by not doing 12 leads, and it's just an extra couple of minutes to do, if that. One of the best things that we need to do in EMS overall is if you are concerned that this is a ACS case and you do have classical or non-classical, just do the 12 lead as part of your initial vital sign set. The American Heart Association recommends that you get a 12 lead within 5 minutes of patient contact, because that is going to decrease the door to balloon time. That's very necessary whenever you do actually have a STEMI and you do take them to a percutaneous intervention center or PCI center, STEMI centers. Now, some of the things that we haven't talked about that are not on the slides here, but is if you are in a rural setting or if you're in a setting where there is no PCI center nearby, what do you do? Do you fly them out? Do you take them to the nearest facility? Do you ground pound to get there? So remember, there's a time when it comes to the strokes for TPA, and there's also a time when it comes to STEMIs for TPA. And it's dependent upon 90 minutes or 120 minutes. And so this is really kind of an emergency medicine thing. And sometimes as it bleeds into the pre-hospital setting, when you call radio report, if you're within a certain window of time, then the doctor may just elect to say, all right, well, you can ground pound to the closest PCI center. Or, hey, we're here, we're in TPA area, let's get them and have thrombolysis. So again, there are some systems that actually do initiate TPA out in the field. Some of our more satellite rural systems where they cover hundreds of square miles, sometimes thousands, and the nearest PCI center is hours away. And so thereby they need to be able to act quickly and definitively. And in those areas, we actually have a lot of great things that are happening when it comes to interventionalism and interventions in the field, where they have telemed and they have mobile sprint vehicles that can either connect visually and verbally, or just verbally over the phone, and evaluating the monitor data, the 12 leads in real time, and making decisions based on checklists and their own clinical acumen to determining whether or not that patient meets criteria for interventions in the field. Fortunately, those are few and far between when it comes to our continuing education needs, and I say fortunately because that's a big decision. That's a lot of responsibility, and TPA is not without any type of contraindications or complications. Remember, it's a thrombolytic. It releases clots, and so if you have any clot anywhere else that may have been blocking something, it's gone. And that means brain, lung, body, GI tract, and so on. And so the interventions, sometimes it's like the old saying goes, the medicine is as toxic as a toxin. And so we really have to balance the risk and benefit when it comes to treatment modalities. The same thing for PCI. The percutaneous angioplasty is not without its own type of problems. The heart vessels are very small, and they're not like, you can just drop a 14 gauge in there and just go along your way. They're small, and so it takes a interventionalist or trained interventionalist cardiology physician to go in and perform these life-saving skills. And unfortunately, what happens is that sometimes that they can puncture through the vessel itself. Sometimes there's a sclerotic block that has penetrated and eroded into the vascular wall, causing even greater problem. And so not all STEMIs have to receive what we traditionally think in EMS is X then Y then Z. And so we have to depend on our cardiology colleagues to be able to find the best treatment for the individual patient they have in front of them. And it's not cookie cutter, it's very specific to the patient. And so with that, I conclude. Again, I say if you have any questions, please let me know. And thank you for this month's continuing education.